Because in a your patient, Faruk
Hi everyone. How are you guys?
We can start now.
Hello, good evening. How are you guys doing?
Fine, sir.
All good?
So fine, thank you.
Rajiv, all well?
So all well, sir. Thank you. How are you, sir?
Great, great. Good evening. Hi Ram. Hi Santosh.
Fine, sir. Hi, sir.
So Ashok is recording these sessions. I am sure people who join in later or don't join in today can see them.
Yeah.
So see, today I wanted to talk to you about trash lesions. A few of you may be aware of what they are. A lot of you may not know what they are. So we'll try to clarify, and it's case based. So I'll expect some interaction and some answers from anybody who's attending. And of course, Premal is here to give the tips and tricks of how to approach. I'll stop at appropriate moments and get his inputs. And I am hoping Taral and Sheetal join in. Taral is going to be here. Sheetal, I don't know. It would be Saturday morning for him there. So if he's around, hopefully he'll join in. So before I start sharing my screen, a quick question. How many of you know what is trash lesions? You can just raise your hands, put your video on, and you can just tell me you are aware of what is trash or what is not.
Yes, sir. We do have an idea, but we are not sure whether we can pick it up or not.
Okay, so we'll clarify that. We'll clarify that for you, definitely. Premal, so shall I start sharing screen?
I think you let us get on with some basic theory, and then by the time Taral should be able to join. I'll message him.
Yeah. Just I've put a small reminder, but I don't know. Try to, if you can call him, we would like to have his inputs. So you guys, do you think this sort of a virtual experiment that we are doing is helping you?
Yes, sir. It is surely helping us.
Yes, it's helping some.
Yeah. Okay. Then it's good.
And I think for those who are not exclusively trained, anything in pediatric orthopedics is helping us, sir.
Yeah.
Virtual,
See,
WhatsApp.
What our idea was, no, trauma is something which every general orthopedic surgeon across the country will have to treat. Because specialized pediatric orthopedic topics only pedipods would be handling, and that too it is always controversial. People have their own opinions. Whereas how to manage trauma is what something everybody needs to know. General orthopods, adult orthopods, everybody is seeing, private nursing home owners, people in public hospitals, people in corporate hospitals, because you have to see them. No?
Yeah, we can't even refer them, like every case we can't refer.
Yeah. And you shouldn't. You should manage it yourself as far as possible. Only certain times where it is really difficult, you may think of referring. Any news from Taral?
I just messaged him. I'm just calling him.
Taral ka message hai. Give me 10 minutes, you can start. Okay. So I just share my screen.
You start with introduction. By the time everybody should join.
Yeah. Okay. Are you able to see the screen?
Yes, sir.
Yes, sir.
Right. Okay. Ashok?
Yes, sir.
Just one question. This toolbar which comes, how do I get rid of it?
Just drag it on the side, up or down, anywhere.
No, that is interfering with my slides. I can't see them. Half the text goes away.
Go on the right side, and there are multiple dots. From that, you can choose the option.
Choose what?
Choose the option which you like.
नहीं, इसमें तो
Dots
कुछ नहीं
are
है.
there, so you can see hide or something.
Hide video panel. अच्छा वीडियो चला गया अभी. हाइड फ्लोटिंग मीटिंग कंट्रोल्स. हाँ गया चलो.
Yeah, the floating meeting control will hide it.
Yeah, but now everything is gone. Now if I want to see the video, what can I do?
You can go again to the same place and start the video.
Yeah, but it is gone. No, the video panel is gone.
Press escape
Okay.
button, you'll get it back.
Okay, एक minute. Sure, because I like to have a feedback of people who are at least video panel रहने दे, लेकिन meeting control जाने दे.
So नहीं तेरे को हाँ chat नहीं दिखेगा. I'll prompt you whatever is the response.
Okay, okay. So you can see the screen now, I guess.
Yeah, very well.
All right. So I'm going to talk.
See.
Yeah. So I'm going to talk to you about the enigmatic elbow, something which probably when we were children, we used to read Mandrake comics and he was a magician. So it's like magic you need to identify. It's always an enigma because this is the common history you will get when a child comes to you. Mother will say, my child had a fall on his hand. The elbow is swollen and it is painful, and you get a plain X-ray done. Now, at the back of your mind, we have done nearly 3 weeks of talking on these two fractures. Supracondylar fractures account for 75% of injuries around the elbow when it is history of fall with a swollen and painful elbow. And lateral condyle is 17% of the fractures. Okay, so if you add them, it becomes 93%. Right? But that still leaves about 7% where it is neither lateral condyle nor supracondylar fracture. Something else is happening with a swollen elbow. And the eyes never see what the mind does not know. So my job here is to make you familiar with what are the other 7% fractures that you should know so that you can effectively identify and treat them. And these have been classified by Peter Waters in a landmark paper which he published in JPO as trash lesions. And why did he call them trash? That means you take an X-ray, you don't see anything, and you trash the X-ray saying, "Arey kuch nahi hai, bakwas hai." But the patient does have a swollen elbow and he has a painful elbow. So there is something happening which we are missing and we need to identify what it is. So a trash lesion is a swollen elbow with an innocuous or a normal looking X-ray. Let's start with this. This is a 9-year-old boy who had a fall on the hand and came with a swollen, painful elbow. Now I want one of you to tell me what is happening here. What is the fracture, or is it normal?
You can put up in chat, or you can speak, unmute yourself and speak. Let me just give you a hint that this is the best time to get wrong. It's never good to be wrong with patients. It's always good to be wrong when you're discussing.
Sir, on the lateral view, I think there's some anteriorly on the radial head, maybe some problem is. Not sure, sir.
Okay.
I think the area you guessed is correct. Sandeep, you want to zoom slightly zoom it, if possible?
Yeah.
Yeah, much better. Yeah. Rajiv has said there's a posterior subluxation of the radial head.
Okay, very good.
Radius may be a radial epiphyseal fracture.
So Rajiv, how did you make out? Rajiv, how did you make out? What were the parameters?
Sir, a line drawn along the mid diaphysis of the radial shaft should bisect the capitulum in all the views, sir.
Superb.
So in this view, it's going slightly posterior.
Yeah, so I will just go to that. Sorry, I have to get this. Yeah, so that is what Rajiv told us, right? You draw a line along the shaft of the radius mid diaphyseal and see where it is cutting across the lateral condyle. And here you can see that it is not cutting across the center and the shaft seems posteriorly subluxed with a little flake of bone here on the head, which again a lot of people identified. In such situations, it's always better if you're not sure to have additional imaging. So a CT scan. Okay. Now, does that confirm your diagnosis? Yes. Yes. So now you can see that this is a radial head fracture. It's a triangular fragment here. And the rest of the radial shaft, along with about 80% of the head, are subluxed posteriorly. And this child came to me nearly 3 months after injury. And he had stiffness in extension. He couldn't extend his elbow completely and had pain. And he was training to be a professional boxer. He was just 10 years old, but he was training to be a boxer. His father was a coach and he had pain and he had been told, your X-ray is normal, go home, nothing is wrong with you. And this is what he had. So this is an intraoperative picture. You can see the epiphyseal fragment here. This is the shaft, and because it was a delay, there are some irregularities and erosions that are seen. So a radial head osteochondral fracture was the diagnosis. I had to do an open reduction and I brought the fragment back into place. And then we fixed it with a Herbert screw, a small 2.7 Herbert screw, and that is the on-table restoration of the radial head, bringing the shaft back and fixing it accurately. And this is what happened. This was his X-ray, as you can see now. Rajiv, are you happy with the lateral view now?
Yes, sir.
Yeah. So now I think it looks pretty decent. The line is now going into the center. That was the Herbert screw that I had used. And I was worried because this child was a boxer and whether I will get back his really the flexibility that he wanted. And we were lucky. And these are the videos with my last fellow. And that was that you can see his crew cut as he prepared for training. And that was his hand back into action. And he's back to his sport. And he started boxing again without any pain. So that was an example, something that you should not miss. Always draw the lines when you see the X-rays with a swollen elbow, the radial osteochondral head fragment. So Premal, any comments on your experiences? Any other tips you want to give on this particular injury?
No, I think it's a very important thing that we need to look beyond X-ray. And sometimes when the patient's symptoms are not in alignment with the radiology, that is the time I think we must be alarmed and we should seek more investigations. Because these are the kids which are highly painful, highly swollen, with a gross restriction of movement, and you don't see what is on one X-ray. And that is why it is called as a trivial radiological abnormality. What is the, radiologically, seemingly abnormal radiology. That is what
innocuous looking X-ray. Yeah. Okay. So that was his function. So we went through that. So let's move to another case. This is a 3-year-old child. Again, swollen elbow and restricted supination. Any takers for this?
Sir, I think here also there is some irregularity on the, but sir, already an arrow is there, so I don't think.
Yeah, this is a textbook picture from the article because I have never seen such an injury. So there is an arrow there, but what is that arrow showing?
I think there's irregularity on the metaphyseal border.
So you think it's rickets?
For that, I think we need additional.
So Santosh, what would you, what if suppose this patient comes to you, what investigation would you advise him? I think the first will be lateral X-ray, but after that?
Yes, sir. Sir, at least at my center, I would ask for an MRI. I don't think anybody would do an ultrasound for this. So
no, even before you order an MRI, what would you order?
I mean, apart from a lateral X-ray, sir?
Yes. Because most of us who are practicing solo.
Maybe opposite limb X-rays I'll order, sir.
Fantastic. I think that is the most important thing to get it done.
Yeah, I think we are successful if we can make your mind think that way. Ultimately, it is training the mind that if you are not seeing something, take opposite elbow X-ray, take a lateral X-ray, take an internal oblique. Okay, these are the three first thoughts that should come to your mind. Correct, Premal? Because it could very well be a lateral condyle.
See, the only reason not asking MRI immediately in a pediatric patient in which you don't see radial head is that they will require anesthesia for an MRI.
Yes.
Yeah.
Right. So I think if we can get away without MRI, it will be the best situation. But if we cannot, I think then it is justified to give an anesthesia.
Yeah. So this particular was a textbook example from Peter Waters' paper. If you can see, this thing highlights, you can see that star here. Yeah. The entire radial head is lying outside because it was completely unossified. So two things that happen when you see a child's elbow. One is you must be really completely aware of when ossification center appears and when it fuses. So at 3 years, the radial ossification center was not yet ossified, and the arrow is showing you irregularity of the metaphyseal bone. So what was seen on X-ray was just the metaphysis and the swollen elbow on the lateral side, and the radial head is lying outside here. This is the capitulum, and this has gone out. It's flipped. Okay, so this was an example where they had to have, this was a radial neck fracture with dislocation of the entire head lying outside and being completely cartilaginous. It was not seen on X-ray. So as Premal pointed out, most of the times when you have a situation where the elbow is definitely swollen and painful, look for soft tissue subtle signs of swelling, and additional imaging is mandatory. Be it X-ray, be it ultrasound, be it arthrogram, be it MRI, depending on what facility you have at your center. Let's move on to the next case. Now this is a 5-year-old. Okay. Any takers?
Sir.
What is this injury?
Middle condyle avulsion.
Medial?
Middle epicondyle
Medial
avulsion.
epicondyle avulsion fracture, correct?
Yes.
Okay. Okay. So anybody else? Okay. So let's go ahead. This is the fragment as somebody has identified, medial epicondyle avulsion. It's on the medial side. This is the opposite X-ray. Is it displaced or not displaced?
Totally displaced.
Totally displaced. Perfect. Okay, so this is what was the diagnosis, medial epicondyle avulsion fracture, and he was treated with observation. Okay, 3 months later, he was not better. Okay, and this was the X-ray. Now, who had answered medial epicondyle? I can't see the video panel.
Karthik sir.
Who was it?
Ram Karthik.
Ram Karthik. So you have to now continue the discussion.
Yes, sir.
3 months later, Ram, now you have this X-ray. What do you think is happening? How do you interpret it?
It's getting ossified there.
Okay, there is ossification. So whenever you see an avulsion fracture, do you think that the size of the fragment keeps on increasing with time?
It's ossifying.
What is ossifying?
That avulsion fragment.
Avulsion fragment is already ossified, no? You saw that on the earlier X-ray. How will the size increase? Yeah?
Yes.
Why is the size increasing? Yeah, it has become larger. Premal, would you like to clarify what's happening?
See, I think that if you have a medial epicondyle lesion and it comes slightly late to you, if it is outside the joint, you will get a reasonably good range of movement. So I think in this cases, clinical examination is very good. So if Sandeep tells me that if this child has a significant swelling on the medial side and he has a significant restriction of movement, I think it's a time that I would take another investigation. He has already shown us that there is no medial epicondyle on the opposite side. See,
Sure.
medial epicondyle appears at what time?
Maybe 6 years, 7 years.
Five to
So it
6
is
to
about
8.
5 years, right? It's 1, 3, 5. So radial head, capitulum, radial head, and then appears medial epicondyle. So radial head is already there in this child. So medial epicondyle
Yes.
should be present, but it is not there on the opposite side. So that tells us that this is not a medial epicondyle fragment, right? So if that is not there, what other structure is there on that side?
It's an unossified medial condyle.
Yes.
So
correct.
unossified medial condyle, and the calcification which you see is probably a Thurston Holland fragment or of type. Which type of Salter Harris injury that would be? That there is an articular chunk with small piece of metaphysis.
4.
Type 2.
Type 2.
Yeah, but if it is a
No,
medial
not
condyle,
type
you're
2,
right.
because
Type
type
4.
3. Yeah, so because your lateral condyle is very much in place. So this is an intra-articular fracture like a medial malleolus, where you have a medial malleolus piece, which is an epiphyseal piece, and you have sometimes metaphyseal piece where you put a screw through. So this is just giving you simile that what most likely this is, unless proven otherwise,
It's a medial condyle fracture. Correct.
medial condyle.
Yeah. So please,
Yes.
please remember this, that the ossification progresses as Premal said. The lateral condyle is always seen because it ossifies at 1 year of age or even lesser sometimes. But the medial condyle ossifies much, much later. But you can have an entire condyle which is flipped or rotated like a lateral condyle. We discussed so much type 3 lateral condyle. Similarly, a medial condyle can come out, and because it has only a small bit of metaphysis with it. Let's go back to the original film. Can you see this now? Imagine this like a Thurston Holland fragment.
Sure.
A bit of the metaphysis has come out, and the entire medial condyle with it is rotated outwards. And in 3 months, that cartilage is now ossifying and the size now looks bigger. Right? So
Yes.
this is what happens, and the true diagnosis is a medial condyle fracture, and this is what happened to this child. Ultimately, he ended up with a bad arthritic elbow with a varus deformity and stiffness, okay, with poor function. So what you should know, again, one more example I am showing you. See this X-ray shows ossification of lateral condyle. You can see ossification dot of the radial head. Nothing on this side, but a large soft tissue swelling and a small dot here. Yeah, can you appreciate that small dot there?
Yes, sir.
And now you do an arthrogram. And what is it showing? That you have a huge big condyle here, which is lying outside and it is rotated. Right? Now this is an intra-articular fracture which needs open reduction and fixation. As Premal Bhai said. Another example, look at this, a 5-year-old child. Look at the subtle soft tissue shadow. Can you see the big shadow here?
Yes, sir. Yes.
And you can see a small metaphyseal flake here. Yeah, even
Yes.
smaller than the earlier case. And look what is on the MRI. The entire medial condyle is lying outside and rotated. So please remember, like the lateral condyle, you can also have a medial condyle which can be intra-articular with a bit of metaphyseal bone, and it flips over and is lying outside. Okay, so please remember the medial epicondyle fracture, which appears like a medial epicondyle before the age of 8 or 9, is always a medial condyle fracture unless proven otherwise. A medial epicondylar fracture is a pre-adolescent or an adolescent injury, which happens around 8-9 years. So if you have a younger child where you think it is medial epicondyle, think twice, because you are likely to miss a medial condyle fracture. Right? Let's move on. Case 4. Again, a swollen elbow, and this is the X-ray. What do you think is happening?
Medial से subluxation.
Pardon?
So this may be a distal humeral, that 5-6 separation, sir.
Yes, so it is not, so this is not an elbow dislocation. This is a transfascial separation.
Facial, sir.
Again, you have to remember, very young kids, the entire distal physis is not ossified. At the most, you have only a small speck of lateral condyle. Can you see your lateral condyle here?
Yes, sir.
And when you draw the line, this is the way the things move. When you have a transfascial subluxation or dislocation, the fragment always moves posterior-medially. Whereas if it is a true elbow dislocation, it moves posterolaterally. The basic difference is that posterolateral, posteromedial, and the relation between ulna and radius is maintained, and the line from the center of the radius goes through the lateral condyle. Right? So these clues are the ones which tell you that this is a transfacial separation. Not, this is like a very low supracondylar through the fascial plate without any metaphyseal fragment at all. Right? So be very, very careful when you diagnose this. This is how it is. The lateral, the medial subluxation, transfacial. So the true diagnosis is a transfacial separation, medial subluxation, and the radial head is in line with the lateral condyle ossific nucleus, right? It has to be treated like a supracondylar fracture. You have to do a close reduction, as you can see here, and this is the arthrogram showing you the entire condylar piece now, transcondylar piece, and then you put a couple of pins to stabilize it, like you do in a supracondylar. So please remember transfacial separations. This is just a pictorial representation for you. Normally, you have the center of the diaphyseal line of radius cutting the center of the lateral condyle. When you have an elbow dislocation, everything moves laterally towards the radial side. A lateral condyle fracture, this line is disrupted and the fragment moves outwards. It's rotated. In supracondylar fracture, they are aligned and you see metaphyseal bone. But in a transfacial, you don't see metaphyseal bone and everything moves medially. So these are the things you should remember when you are diagnosing a transfacial separation. Let's move on. Premal, any pointers here? Additional pointers, comments, discussion on transfacials?
The only thing is, if the child comes to you at about, say, age of about 6 or 10 months, how do you reduce and fix it? I think we had a discussion on group where one patient which was sent to me by someone else, which we discussed. So the question is, suppose the same child is about 8 months old and you get a fracture, how will you treat it? Now that you have diagnosed, the treatment is very important. In newborn, you may miss it. It may come to you maybe about 6 days down the line, which generally happens even to us. In that case, we may not be able to treat it. But what will you do in a, say, about 6 weeks or a 6 months old, 9 months old? I've seen all this injury, maybe 1 year old, when you don't have lateral condyle epiphysis still ossified. So how do you treat that child? How will you reduce it? And how will you confirm the reduction? Because you can't have anterior humeral line except alignment of distal humerus with forearm. You don't have any bony structure. So how do you do it?
Yes, anybody?
The diagnosis is just one part of it. The second more important part is
We will
treating.
have to go for open reduction.
Taral, if you can chip in here, in neonates, when you get transfacial separation, will you go for open reduction?
Sir, we can do an orthogram and perioperatively, can we compare with the opposite limb?
Yeah, that is the best solution. That if you do an arthrogram, you will be able to delineate your distal fragment, and then you will be able to pass your pins properly. Otherwise, you will not know where your pins are going. So this is one of the indications where arthrogram is must. Right? It's a good idea for you to begin next time. Whenever you have any elbow injury, try put some dye in it and try to start play with conditions which you have already preoperatively diagnosed. That will give you much confidence of doing the arthrogram and interpreting it. And then when this complex things come to you, you may be able to come back and do it easily and give good results.
Yes, Taral.
Yes, Sandeep, you want to go ahead with your next case?
Is Taral around? I saw his name.
Yeah, he's there.
Yeah, Taral. So can you just highlight in neonate, if you see, will you pin every case? What is your approach?
So we have reviewed 5 cases of neonatal transfacial just recently, and what happens is in each one of those cases, though I am attached to a hospital where neonatology department is present, by the time you actually see the child, it's 5 to 7 days, and by that time, that transfacial injury almost is like healing. It shows callus formation. There is no movement, and in that all you end up doing is just immobilize in a slab for a week or
Slab.
so.
Yes.
And in none of those patients there has been any residual deformity or varus. It all remodels very well in neonatal age. So
Correct.
supracondylar varus does not remodel. But if you see a neonate with transfacial fracture which is malunited, in most of those varus will remodel because the
Correct.
level of injury is completely different. What is your experience, Sandeep, about?
Correct. That's what I wanted everybody to know, that if you are attached to a pediatric hospital or a place where neonates are accessible to you, sometimes you will get a reference even fresh on day one. And if I get it fresh on day one, my approach is to put it in valgus as much as possible. Okay, I may or may not do an arthrogram to confirm my reduction at a neonatal age we are talking about. And then what I do is, the cartilage, as I said, is so soft. No, I use a 18 gauge or a 20 gauge hypodermic needle, and I pass it like a K-wire from the lateral side to stabilize that fragment and give a slab. And as Taral said, in 7 days it comes up. If you are lucky on day one, if I've got the case, I do that. So make sure your hand is in clinical valgus and put a small pin. If you have the access to the OT and you do a 1 mm pin, that's fine. Or you can do this sort of a jugaad that I do, is that I just put it in valgus and pin it with a small hypodermic needle, stabilize that fragment for some days, and it gums up, and then just a slab. And compared to an older supracondylar, these neonatal things tolerate varus better and they remodel better, though all do not remodel. I have had long follow-ups of transfacials who have ended up with varus which needed correction also. But the tolerance to accept varus is higher in neonates than in older children. Right, Taral?
Yeah, absolutely.
Sandeep,
Yeah.
just to complete this, I think that the latest edition of the Rockwood and Green mentions that many centers do not have access to neonatal anesthesia. So
Yeah.
best thing is to, as you said, that you apply a slab in about, say, 30-degree flexion with valgus.
Valgus. Absolutely.
Because the only thing which does not remodel at this age is varus or valgus. So if you can maintain valgus, your posterior displacement, which is going to be there, will remodel in about 1 year time, and you get an excellent result.
Yeah.
And so this is not my recommendation. This is a recommendation of Rockwood and Green, because the centers you may be working may not be very comfortable giving anesthesia to a neonate.
Right.
So this is the best thing you can do.
So first thing is identify the injury and then decide what. Yeah, sorry, there was a question.
Yes, sir. Sir,
What is the cause of the injury? Yeah, please ask.
Sir, recently I've just seen some people share a case where one of the pediatric orthosurgeon has managed it only with reduction and immobilization. Is it okay, sir, or should we definitely fix it with some sort of pins?
In neonate, you don't need to fix, because the area of fracture contact is much wider compared to supracondylar. So once you are able to get a good alignment with more than 90-degree flexion, if your circulation is normal, you can just apply slab in about 110-degree flexion and slight pronation, and that is again a recommended treatment. I have never ever fixed a neonatal case, but only thing, as Sandeep and Taral said, I got only 2 cases which came to me within first 4 days of life. This all came a week later, where you cannot do anything, and you should not do anything.
Sir, one question. Sir, I had one case which came after 12 months of age. So it did not remodel. The virus did not remodel. So how much time should we wait in this case?
The virus will not remodel. In neonate, if the virus is less, then some chances are there that it can remodel. At 1 year, for sure, virus will not remodel. If the parents want correction, you can offer correction when you are comfortable doing it. I have done as young as 2.5 years old. Cubitus virus correction. And the parents were demanding. So as my teacher said, what is the best time to do cubitus virus correction? So as my teacher, it was a favorite question of my teacher in postgraduate exam, and the answer he expected was when you get a full extension. Because in full extension only, you will be able to measure exact angle of deformity. If you take full X-ray, elbow X-ray in full extension, you will be able to exactly measure the carrying angle of the involved as well as opposite side. So once you get a full extension, anytime you can do, provided what is your level of experience doing this something. But if you wait for a couple of years, there should not be any problem. Karan, you wish to add anything?
So cubitus varus, again, I don't operate at very young age. I think youngest I must have operated is 6 or 7, not earlier than that. It's not very easy to do a cubitus varus correction in very young children. You don't get good fixation, anatomical landmarks are not good, and it's a very small elbow. And it's not an emergency surgery. You can wait and see what is the child's deformity and do it later on. So I have not done, and in fact, nowadays most of the patients we get, generally we end up doing at 8, 9, 10 years. Yeah, Sandeep.
Complete your this thing.
That is it. So because this is about supracondylar maluniting.
Yeah.
In cubitus varus, which follows infantile fascial slip. In a very small elbow, the deformity is also not very apparent because so much of fat around the elbow. It's only later on that parents start appreciating these deformities.
Yeah. So I have had cases where the deformity has remodeled significantly till about 4 to 5 years. So for a transfacial separation, which I have seen at neonate and is in varus malunited, I have cases like you said come at 3 weeks with heavy callus and good amount of varus. At least 70 to 80% of varus has remodeled and the angle has reduced dramatically. I have documentation. So I will wait for at least 5 years to answer Vivek's question before attempting any kind of corrective osteotomy.
So I agree that Sandeep, I have never operated a fascial separation which led to cubitus varus. But suppose you get a supracondylar fracture which was missed in about a year, year and a half.
Yeah.
And then if that gets cubitus varus, that will not correct.
Yeah.
And you
so 1 year of remodeling and full
you...
extension is the answer.
Yeah.
What you are saying is right for supracondyle. Okay. So shall we move on, Taran?
Yes.
Yeah. Okay. So this is the next case, again a swollen elbow, and this is the X-ray. So can anybody make out what's happening here?
Loss of fat pads. So there's
radial head looks to be translated in proximal radius.
So there is a swollen elbow. There is no full extension. That X-ray is in slight flexion. If you can see the lateral, no, in the same angle, AP has been taken. That is why you are seeing that there is some twist to the radius.
Loss of fat pad sign, sir.
Fat pad sign, swollen elbow, yes, swollen. So
there appears to be a plastic deformation of the proximal ulna.
No, so this child was sent away and he came back after some time. And he had X-rays which were then treated in a slab, and this is how he ended up. Right? And then when you go back to that earlier X-ray with a very close view, you can see that small crack there. It was actually...
Sandeep, you are not audible.
Can you hear me now?
Yes, sir.
A little better.
Yeah. So this was a Monteggia lesion. So some observations were right that there is some radial head malalignment as compared to the lateral condyle. But sometimes, with massage, incomplete cracks like this, treated by traditional bone setters, can get displaced. So this child, he went for local treatment in local bone setter who did malish, and this is how he ended up. So the next subtle Monteggia or Monteggia variants are the ones which you should be aware of, which can also be trash lesions. So every cubitus varus is not always supracondylar. It could be lateral condyle malunion or overgrowth, pseudovarus, or a Monteggia with a radial head which is laterally subluxated. Next case. Who's going to take this? This is an interesting one, and I want inputs from Taral and Premal as to how they approach.
Sir, what was the treatment for the previous case which you opted for?
That child underwent an osteotomy, proximal ulnar osteotomy.
Okay.
So what is this diagnosis? Anybody?
So there's a swelling on the medial side.
Medial side,
Swelling on the
yeah.
medial side. And the medial epicondyle looks to be displaced. The
It
space
looks
has
like
increased
advanced.
in there.
So could this be an olecranon or sir? Do you have any other X-rays? Sir?
No, I want you to come up with two questions to me. First was, do you have any other view? Second is,
Normal limb.
we just taught
Opposite-
you know 5 minutes
opposite-
ago.
Opposite hand.
Opposite-
Normal limb.
Opposite
No,
elbow.
Perfect.
The
Positive view.
no. Two
So it is
questions I
occupied.
want you to ask me. One is one more X-ray, either opposite or you want a lateral. What else?
That
Whether it's injuries,
Single rotation view.
age of the child.
Age,
Internal
very
rotation.
good, very good.
You
Nobody's
already put
asking
up,
that.
Sandeep, you already
sir,
put up age.
age is 10 years. It was written.
Oh, it is written. Kya?
You
Yeah.
already mentioned it. That's why.
My panel is not was covering it. I couldn't see that I have written it.
Ah.
Sorry. So at 10 years, obviously, this is more than 5. So at this age, we are not going to think about a medial condyle. Okay. So yeah. So sorry about that. Now this is lateral.
See, it is very interesting. Sometimes you see medial epicondyle much better in a lateral view, sometimes in an anterior. It is because it's not dead anterior, it is slightly posterior. So if you're looking for medial epicondyle in a comparative X-ray, try to look in lateral X-ray also if it is not visible on EP X-ray. If it is
Yeah.
visible in EP X-ray, that's perfect.
So Taral, what is the recommendation today? Should we operate at 10 years on a stable elbow with a medial epicondylar fracture, or it is conservative is okay?
So in fact, there are varying views. There are people who operate and people who don't operate. But I think it's much easier to go by stability of the elbow. If the
Excellent.
elbow is stable,
Yeah.
then even if the displacement is, like what you see here is, looks more than 5 millimeter, you can conserve medial epicondyle and they will do well. It also depends on what are the demands on that elbow. So if this child, 10-year-old, was a, under 12 cricket player who was bowling with the same hand, in that case, there may be some reason to fix it because that stability is required.
Absolutely. So stability and demand, irrespective of displacement. Lot of papers and lot of people are saying that one is that additional imaging. There is a paper which says that you must get a CT scan because that will show you the true rotation because of the fragment, and malposition of that fragment may lead to instability as well as ulnar neuritis, and in a high demand elbow, gymnast, sports person will need accurate fixation and stabilization. So how do you assess stability? In a painful elbow, swollen elbow, Taral, can we do stress testing?
Not really.
Clinically, without anesthesia, it's not possible.
Yeah. So then we are committed to doing some kind of treatment, right? If you are going to do arthrogram and anesthesia. So this particular child, again, like Taral said, he was playing tennis and they were keen to, I believe always that a displaced epicondyle is an avulsion injury, and putting it back will give best stability because there are additional injuries to the flexor compartment also. So this is to show you that, see, this is the varus stress. You can see how much the medial die pool has increased and valgus instability. So the medial collateral is getting pulled with that fragment, and that we had to open and identify the fragment, identify the footprint from where it came, and then fix it accurately. So Taral, any recommendations on the fixation modality? What would you do? How would you go? Because it's such a small piece likely to fragment.
Right. So generally, it has to be a very stable fixation. And again, from younger age group to older, there are choices between pins and screws. In older children with a big fragment, I always prefer a screw. But when the fragment is small, when there is fragmentation, you have no choice but to fix with multiple wires. What I always do whenever I fix with a wire is I take a stitch There are two options. Either you can take a stitch with a 2-number ethibond or something, make a hole through the lateral crest of the medial crest of the condyle of the epicondylar region. You pass a suture through it and suture it through the common flexor origin, and that maintains the stability in addition to the wire.
So the tensioning of the medial soft tissue is important.
Is very important. And I in couple of times when there are arthroscopy guys around, we've also used suture anchors.
Yeah, suture anchor is the next thing. Correct.
Yeah, stabilization of the medial collateral complex.
Taral, you have muted yourself. So there is one very good practical tip where the technique paper described when the fracture of medial epicondyle comes slightly lower, the flexor attachment pulls the fragment much distally.
Yeah.
And sometimes it is not possible to bring it back to its original place. So in those cases, what you can do is you can start applying ash mark bandage from the wrist so that the fragment is milked up and you will be able to easily put it back in that place. So this is just one practical tip which has been published.
Right. So what I did was I temporarily stabilized it with a pin and then I put a compression screw, and that has given him excellent stability and a good range of motion, and he's back to his activity.
So Sandeep, do you need a bicortical screw in this?
No, it is not necessary. It is not necessary to put a bicortical screw as long as you have a half threaded. No, you don't need a full thread. You must use a half thread with a washer to get good compression against metaphyseal bone.
Sandeep, again, your voice is getting very faint.
So one of the tips I'm going to give is if you are putting a screw like this and it's such a good fixation, I may put in a slab till the time edema subsides and patient becomes pain free. But don't give plaster for 3 weeks or 4 weeks and mobilize after fracture heals. You need to start mobilizing them pretty early. Otherwise, they tend to become stiff.
Correct. Absolutely, I agree. Recently, I had a patient, a 13-year-old girl with a 6-month-old untreated medial epicondyle avulsion fracture, and she is training to be a wrestler from Balewadi in Pune, where they have this young athlete training center. And they had treated her conservatively and she just couldn't manage. So we had to really dissect because there was a fibrous non-union, but it was mobile even at 6 months. And then we had to improve the station. It had gone down and we had to put it back and use a compression screw again. Like you said, we gave a slab for a week. After the wound settled, we started early range of motion. Right. So next case, now this is a child who had a fall. Again, you can see the hugely swollen elbow. This is 1 month post-injury and the child has got pain and stiffness. Can anybody tell me what is the diagnosis here? Hello?
Yes, sir. Delegates also can type in the chat.
Yeah, you guys look at the chat because I have hidden my controls, then I can't see anything. Otherwise, I block my own screen.
So what questions you want to ask Sandeep? Sandeep asked
one is
two
age.
questions last time.
Age is 11 years.
There is a small metaphyseal. There's a small piece near the ulna, medial side ulna.
Medial of ulna.
Okay, this one.
So what other investigations will you do?
Sir, opposite elbow.
Correct.
Sandeep, do you have opposite elbow X-ray?
No, I have his original film. This is what he had at time of injury, and that was reduced, and you had a trapped fragment. So medial epicondyle we saw can be isolated or with an elbow dislocation. And when it is with an elbow dislocation, when there is a relocation maneuver or spontaneous relocation, you can have the epicondylar fragment getting trapped within the joint. It's very important for you to understand that also. Sometimes the ulnar nerve can also get trapped. This is something that is called as missed incarceration. So if you get an elbow which is disproportionately swollen, somebody has reduced it or got spontaneously reduced, but you feel that there is stiffness, pain, and a fragment seen there. You can get additional investigation in the form of CT or MRI to confirm, but don't ever miss a trapped fragment. You will have to open the elbow and either excise it or repose it and do arthrolysis to get back range. Otherwise, the cartilage gets permanently damaged. So in this particular case, I will show you the clinical pictures. You can see the ulnar nerve trapped inside. This is the footprint of the fragment. The fragment with the ulnar nerve was in the joint. And I had to take that out, take the nerve out, redislocate the elbow, pull the fragment out, and then put it back where it belongs. And then we could fix it with a screw. Now, this is another example.
Sir, one question.
Please go ahead, Vivek.
So, what should we do, CT or an MRI? Because MRI would reveal more information regarding the physis and the soft tissue as well.
Yeah, you can do either.
Okay.
And if you're sure, you don't need to do anything actually.
Yeah. So this particular case, again, similar, you can see dislocated elbow with a medial epicondyle with a little bit of condylar fragment. This is put back. Yeah. So the elbow is now reduced. The fragment is not trapped. Taral, should we fix this or accept this and leave it?
You're asking on this X-ray?
Yeah.
This is a funny fracture. It's not a medial epicondyle. What is the age of this child?
Again, similar 9, 10. It's a pre-adolescent age group.
See, the difference, Sandeep, here is that you have an epiphyseal piece as well as metaphyseal piece.
Yeah, so it's a larger
Definitely.
piece. It's not only the epicondyle, it's a condylar fragment, like a shear.
So between this piece, there is cartilage in between. So
but it
so
was
this
like
requires this requires more imaging. Definitely, you can't just. I would not discharge this child.
No, looking at the original instability, can we conserve or we must fix it because it's rotated, Taral?
Yeah, it's look, there is more than epicondyle to this fragment.
Yeah. So there was an example where because of the extensive soft tissue injury, there was because of extensive soft tissue injury, there is a lot of callus formation also. Okay, but this can be an exception. In that particular case, Taral, I did open that fragment and it was like a shear fragment. Part of metaphysis, part of epiphysis with epicondyle.
Right.
So that's the arthrogram. And then we fixed it with a screw to restore the stability.
Yes.
So you can get a varying sort of a combination, funny kind of fractures with fracture dislocation elbow. Taral, any inputs on fracture dislocations here?
Yeah, so fracture dislocations are very scary in pediatric age group. So there are various combinations, Sandeep. You can have medial instability with fracture dislocation. You can have even more difficult to manage are radial neck fractures with dislocation. So you have to have injury on medial side and lateral side. And many times we fail to organize to see that in children with dislocation, there can be injury on both sides. So one must look for that. And dislocations and fracture, really need the good management.
Yeah. So I think we will have a separate session on radial neck and head because that is an important topic, Taral.
Yes.
Yeah. So let's move on. 8th case, 3-year-old child. Anybody wants to take this? Is there any injury or no?
Another view of X-ray, sir. Opposite hand.
Pardon me?
Any other
view you want? Any other view? Yeah. Oblique view. Internal.
Lateral condyle. Lateral condyle level. Epiphyseal.
Look at
lateral epicondyle
look
separation.
At the soft Soft tissue also we look at.
What is the age when lateral epicondyle appears? Lateral epicondyle appears the last.
11, 12 years.
Yeah, so epicondyle, lateral epicondyle नहीं होता है at 3 years. Yeah, so what is it?
A lateral condyle injury
See,
itself.
I showed you the line. See, the ulna and the trochlea are in line, elbow is in line.
Sure.
Radial head to the capitulum, is it correct, or you feel this fragment is not in position?
Not in position.
Not in position. And look at the amount of swelling. When you take oblique, can you see double density here?
Yeah.
Yeah. So it's not ossified, but this is after arthrogram. See what is shown. What is it now?
A lateral condyle injury.
Yeah, it's just a lateral condyle fracture in a very young child where the ossific nucleus is also just a dot. There is no ossification yet in the lateral condyle. Okay,
this is one of the case in which you are justified doing an MRI, because in this case, if you do a CT scan, you are clueless.
Yeah. So MRI for cartilage, yes, always. Or if you are going to offer treatment where I knew this was lateral condyle, I did directly under anesthesia arthrography because I was going to fix it. So this was fixation and arthrography after that. Now this is more obvious. Yeah, when you have a metaphyseal fragment, the lateral condyle becomes more obvious. We have discussed a lot of lateral condyle, but again, this is part of, just give me a moment. Battery running low. Okay, so this is part of the trash spectrum, a lateral condyle fracture. Again, somebody put it in plaster. We have seen this yesterday when Taran spoke, and that got displaced and went into non-Indian. So, again, a related revision, a metaphyseal fragment.
Sandeep, sunai nahi de raha hai.
Can you all hear me, please?
Yes, sir. No, sir, not so clear.
Okay. See, I have a problem with my voice, not with the machine, my vocal cord. So please bear with me in between if it goes away. Can you hear me now?
Yes, sir.
Okay. So when you have a metaphyseal fragment, you have to find out whether it is going into cartilage. You can investigate by MRI. If it is not going across the cartilage, you can conserve it and it will heal like this. Or if it is going into the joint line, you know that synovial fluid will interfere and this will rotate off and it is better to fix it. So we prefer to do arthrography. You see the dye leak, you see the instability, and then it's better to stabilize this fragment with an innocuous looking fracture X-ray. So be aware of that and put a pin to stabilize. 9th case, older child, swollen elbow, went to a joint replacement surgeon, was told normal X-ray, sent away in a slab, came to us after about 6 weeks with a painful stiff elbow. Anybody, what is it?
Posterior dislocation of the radial head. Capitulum fracture.
Posterior dislocation of elbow? No.
I had the radial head and capitulum fracture.
Anterior bump can be seen, sir, above the radial head.
Okay.
Capitulum.
Look at the lateral view.
Normally on the lateral view, what is the inclination of the lateral condyle? Which we always say while supracondylar.
Anteriorly angulated.
Yeah, how much?
40 degrees.
35 to
about
30 to 30.
35 to 40. Is this
40,
that much or it's more?
It's
more.
It's more, sir. 90 degrees something.
Yeah. So the fragment of the lateral condyle looks 90 degrees. It's flexed. Okay, and this doesn't look congruous at all.
Yes.
So with a better X-ray, proper lateral. Now what is the fracture?
Capitulum.
And shear fracture of the
Absolutely. So this was a shear fracture of the capitulum, which was missed again, and they thought it's innocuous because of a badly taken X-ray, and the CT scan confirmed the fragment, and this had to be open reduced, right? You can see the shearing fracture and the cartilage piece there, and then again Herbert screw to fix it and restoration. So trash lesions for all of you are a group of osteochondral injuries, which if treated insufficiently will always result in long-term chronic problems. You need a prompt diagnosis and a very high level of suspicion. You will always need additional imaging. It could be oblique view, opposite X-ray, ultrasound, arthrogram, or MRI, depending on your situation. Most of them will be displaced and unstable, and most of them will require surgery, those 7% which I talked about earlier. Ultrasound is inexpensive, it's dynamic, but it is operator dependent. MRI needs sedation or anesthesia and is more expensive. Arthrograms are dynamic and functional, which you can do and interpret, but there is a small learning curve, and beware of dye leak. So do not trash a swollen elbow in a child. Supracondylar and type 3 lateral condyle are not the only fractures. Use additional investigations as per your availability, affordability, and experience, and always be ready for surgical intervention. Please go and read this JPO paper by Peter Waters, James Beatty, and James Kasser. What is the list that they said, which we covered today? Osteochondral fracture with joint incongruity, radial head anterior compression fracture with posterior subluxation of the shaft, Monteggia fracture dislocation, lateral condyle avulsion and shear fractures, unossified medial condylar fractures, unossified transfacial separations, entrapped epicondylar fractures, and complex osteochondral fracture dislocations under 10. I think we covered most of them. Thank you very much. And I will invite Taral and Premal to give closing comments and present their case.
So Premal, you can go ahead.
Okay, so I'll just show two cases. One is similar to one Sandeep has shown, but I've treated it in a different way. And then I'll show another case. Can you see my screen?
Yes.
Okay, so this girl, 9-year, fell at school. This is the injury film. Anybody wants to make any comment here?
Small fragment is seen anterior to the capitulum.
Here?
Yes, sir. Yes, sir.
Okay, yeah, it could be that. You want me to enlarge a bit? Let me see if I can enlarge. Yes. Sandeep, do you feel this is a concern? But if you look at this, she's developing ossification center of medial condyle or trochlea. So she's at that age at 9. In females, you tend to get ossification center there.
Irregular ossification, yeah.
So, and that is irregular, and that does sometimes mimic like a fracture.
Okay, so at least from the given X-ray, I think there's a swelling on the lateral side. So
the radiocapitular line looks to go posteriorly.
So this is okay. This is somewhat fishy, right?
Yes.
Anyway, just we have spent a lot of time on this, so let me get back to. She came to me after 4 months with restriction of movement. So she has about 40-degree movements, and this is her X-ray at this point of time now. If you can look at here, these two shadows which we've seen earlier also, they are the medial condyle ossification, which is abnormal at this age, which is irregular at this age. And here you can see, this is the fracture which Sandeep showed. Now this is 4 months old, and she has a significant movement restriction. What should we do now?
So MRI would help.
Okay, MRI.
I think there's a radial head, anterior shear fracture.
Piece is there.
So what is the difference between this case and the case which Sandeep showed? We'll get back to the X-rays again.
There was a progressive
There is no
subluxation in that
subluxation in
case.
this case.
Do you feel there is a subluxation here?
No, sir.
So this line is very, very intact, and MRI does show that there is a fracture of the radial neck, type 4. Right? So should we fix it or leave it?
4 months old.
We should fix it. As there is recession of the movements, we should fix it.
Sir, any other images of MRI?
So I think these are the two most relevant images. That's why they are here. I have a lot of other images, but these are the most important ones. There is no lateral subluxation. In lateral view, there is no subluxation even on MRI.
So I think if it's only restriction of movements, 4 months is a short period to decide, sir.
What will you do? Suppose this patient comes to you, Santosh.
Maybe I'll.
Well, what will you do? Sandeep has already shown a case in which he had done a fixation because the child had significant demand on his elbow, whereas he was a boxer. So this is a.
Sir, what about mobilization under general anesthesia?
Mobilization
Under general anesthesia.
And then
manipulation. He means manipulation.
Yes, I understand. Then will you immobilize or not immobilize or start?
No, we won't immobilize, sir. Start range of motion.
Carol, you keep it. Okay, let's get further. So what I did was I just immobilized her on an OPD basis and thought that it could heal. So it healed very well in some time. And this is her function at about 4 months time. Right. So I think if it's an elbow is not demanding, you need to identify that this is a lesion, and these are the trash lesions we have already seen. Right. So this may not be the best treatment in a case, but sometimes, if the parents are not demanding, even the child is not demanding, this could be one of the things which could be offered. Ultimately, what you need is good range of movement and a stable elbow. So
Premal, I'll just make one comment here. I have treated 2 patients with radial head fractures like this who healed spontaneously, but they went on to develop progressive cubitus valgus because of growth arrest. The proximal radius stopped growing. They had significant growth remaining, and they came at maturity with the radius being shorter and valgus instability.
So, Sandeep, I completely agree with you. So this girl is already 10 years old.
I'm not saying that at 4 months I could have restored it, but this is one of the complications that may happen.
So this is a very known complication that radial head fracture, they go on to develop physeal fusion. So that is expected to happen. But when it happens in a girl around 10 years, the consequences are less. Actually, I have a serial X-ray on this girl in which this side fused earlier compared to opposite side. But fortunately, on her 3-year follow-up, she does not have any functional limitation. After that, she has not followed up. So it's a very beautiful.
I want people to know that radial head also causes growth arrest with progressive valgus secondary.
Yes. Yeah, radial head fracture. Radial neck is innocuous, but radial head and neck are different fractures.
In radial neck fracture, the blood supply to the head is preserved.
Yes.
A branch of the metaphyseal vessel. And radial neck fracture, even though it is displaced, very rarely will undergo avascular necrosis or physeal fusion.
So this boy who had swelling and pain over right elbow due to fall before 2 days from a bicycle, he went to an orthopedic surgeon. This child did not have much pain, but there was significant swelling and restriction of movement. And these are the injury films. On left side is the first film, and on the right side, it's a spot view of the elbow. He couldn't extend the elbow properly. And this is what he was. I'll show you more clinical pictures, but there's a tenderness all around the elbow, and there's a significant swelling, as you can see in the lateral view.
Yeah, I think again this angulation in the distal humerus is different.
Sorry, Santosh?
Sir, I think again the distal humerus slope on the lateral view
Is not normal.
changed.
Absolutely,
Not
yes. So
normal.
it's more in flexion. So what will you, what investigation would you need?
CT scan in this case.
Yes.
CT scan.
So suppose you don't have CT scan in your clinic, what first investigation will you do?
Program.
Rotation.
Sorry?
Internal rotation view, sir.
Or even better, comparative view, right? So these are the comparative.
Arthrogram.
No, arthrogram is an invasive procedure. So before you decide to do anything,
Compared to opposite.
so this is the
Compared with
comparative view.
opposite.
What is happening
Okay.
here? Somebody was talking about fat pad sign. You can see the fat pad sign beautiful here.
Yes.
So that tells us where is the injury. So now I'll give you the clinical picture of this child. There's a gross swelling and about 20-degree movements possible. And if you look at him, he is not able to hold his hand. He has to grab his hand by opposite upper limb. And if you see, there is hardly any movement at elbow. Whatever he is moving at shoulder.
Okay.
So now what? Taral, what do you feel here?
Something fishy.
What investigation? So this really came as I couldn't diagnose it from X-ray. As somebody has said, I felt that there's something wrong in the distal end of humerus, which was
Did
slightly.
he have fever?
No, it's a post-traumatic 2 days old injury. Fell from cycle and immediately happened.
Fresh injury.
Fresh injury.
Can you go back to X-ray? Okay, and the next one? Achha, this is comparative.
Yes, comparative. The right bigger one is the injured side.
Okay, can you go back?
Sorry?
This, which one is the injured side?
The bigger one.
This right side?
Yes.
Okay, I think he has a low flexion type of supracondylar fracture.
Yes, that's what I presume. And this is his MRI. We couldn't see much on the MRI actually in this child. There was significant swelling, but MRI could not give us much information. So we did a CT scan simultaneously. This is the CT picture, but it is only when we saw this, we got the diagnosis. So this is a shear type of injury to the distal humerus, which is exiting very, very low.
Very low flexion.
Yeah, very, very low flexion variety.
Sir, in the AP X-ray, there is some bone fragment laterally.
Premal, if the fat pad sign is positive on X-ray.
Yes, that's what I showed. The fat pad sign gave us an indication that this is something is happening to distal humerus.
That's why I thought it's a supracondylar flexion type, which it
Yes.
is, but it is very low. It's much lower than I thought.
Yeah, it's a distal end of the olecranon fossa.
Absolutely low. And it's comminuted, as you can see. So again, additional imaging whenever in doubt.
So what to do now, Sandeep?
Yeah, reduce it and fix it. And warn about avian and do arthrogram on table.
So this is instability as seen in IITV examination. This is arthrogram. If you look at in extension, it appears slightly better. This is in flexion, this is in extension. And this is also unstable. But articular surface was pretty good. So I just pinned it in situ. This is the final fixation. and this is at Union.
Yeah.
And this is 1 year later.
Great.
He has not bothered to come back. He was good enough to send his clinical picture. So I'm not sure whether he has developed AVN or not. I cannot be 100% sure. But I've never seen the supracondylar as low as this. So this is probably not mentioned in the list of trash lesion, but this can be, this can be classified as the one in which you cannot diagnose of this on X-ray. Carol, your comments on this?
Yeah, extremely interesting. It was like an oblique shearing fracture where he must have fallen in flexion like that, and the olecranon tip has taken away extreme low end of humerus with
This was a really challenging in diagnosis. So imaging for such patients in which your radiological signs are trivial is one of the most important lessons of today's session. So do not hesitate getting, and the most important thing I would say is that if your radiologist is not able to give you correct answer, ask them to send few relevant images on WhatsApp. And if suppose CT scan is not able to diagnose, ask him to get an MRI done at the same site, because most of the centers nowadays have both the facilities available. It's vice versa. If the MRI you ordered did not give additional information, give a CT scan. And if you order CT scan and if you think that additional information you didn't get, you order an MRI. But you need to get a diagnosis before you go in, because in such cases, even arthrogram won't give you much information. So these are two cases from my side. I think we had significantly exhaustive discussion on trash lesion. Probably this is probably the biggest symposium on trash lesion it has ever happened.
That is why we have this fellowship. We can take our own sweet time and discuss in detail.
One last case from me.
Yeah, Taral's case.
Yeah, Taral.
So this is reverse thrash lesion. One second.
So suffice to say that those 7%, those 7% cases other than supracondylar, lateral condyle are all operative cases. So please don't miss them. All of them need surgery. All of them cause stiffness and complications.
More of cash lesions.
Cash lesions and trash lesions.
So this is a child who had injury to the right elbow, and this is the history that he had an injury and he was diagnosed as a radial head dislocation, and he was treated in plaster, reduced and treated in plaster, and he presented to us with a flexion deformity. Okay, so this is the injury he had. So I want to again ask people, the delegates here, what is the trash lesion here? What do you think is the injury? How should we treat this? Sudden history of fall.
Can you enlarge this? It's a beautiful X-ray and excellent teaching points in this.
There is proximal diagonal synostosis and with a radial head dislocation.
So I think here it's angulated. Maybe was it a missed Montage or something?
A cross union, post-traumatic cross union.
Cross union with the angulation of the proximal radius. Yeah, definitely the radial head is.
You see between proximal radius and ulna at the metaphyseal level. I think the clue is very, very there.
So,
Olecranon process is deformed, sir, and anti-dislocation of the radius and sinus radius and ulna, proximal radius and ulna.
So what will you do for this?
Next thing would have been examine the opposite side.
Yeah. So Taral, can you?
Absolutely. So this is congenital radial head dislocation.
Yeah.
It is not traumatic radial head dislocation. And clues to a congenital radial head dislocation are it will be bilateral. But if it's unilateral, it may be associated with proximal radioulnar synostosis or deformity of the radial neck or widening. It's a wide radial neck. So you'll find these radiological changes. And when you see that, even in a post-traumatic elbow, you must recognize that congenital radial head dislocation may be present because it's not very rare. Not very rare. So we did a CT scan for this patient. The problem with this patient was that with the age, the radial head became quite enlarged. And that produced a block to the child in extension. Once he fell down and had fall on outstretched hand, this produced impingement and got trapped into extension. And the person who reduced the radial head under anesthesia, he got him into flexion and then blocked him in flexion. So that was the problem. And treatment, this has been very well documented. And the treatment is radial head excision. And then this is how we did it. So we went through an anterior approach. So very rarely we do an anterior approach to the radial head. Most of the time we do a Cocker's incision, lateral approach. But this is a patient when we went through the lateral head, to the anterior approach. The reason for doing that is that here you have to identify the posterior interosseous nerve. So you can see the lower radial or the posterior interosseous nerve here, which has been dissected. And after dissection, you mark the radial. It's pretty big. It's bigger than what is seen on the X-ray. So you remove the radial head from the neck area. How much do you remove? You have to remove as much as required to remove the impingement and get the movements back. And following this, he had good range of movements on the table. So you can see that he's able to suddenly free movements possible on the table. What do you do about radioulnar synostosis? His forearm was in mid-prone position, did not require any treatment. So you leave radioulnar synostosis as it is. Don't touch it. If the forearm was in a deformed position, in say full pronation, and he could not supinate at all or come to mid-prone position, then one would have done osteotomy of radius and ulna to restore the to give a functional position. So this is the long-term result of this child. The left side has the same pathology, but has no problem, so we have not treated. It was treated only on the right side. So this was a reverse thrash lesion. It's a non-traumatic radial head dislocation, which requires recognition and a different treatment. And there are a number of normal variants in a pediatric elbow. And one of the common variants which Premal spoke about was ossified medial condyle. Many times it is reported as fracture or fascial injury. So, you have to be aware of normal variants as well as normal development. And again, as Sandeep said, that elbow injuries are not only supracondylar and lateral condyle, there are many more. And you will come across them in your lifespan. And if you have attended to this talk well, and if you read Peter Waters' article now, I think there are chances that you will be able to recognize and treat them very well in future.
And I think the minute you recognize one of them and treat them efficiently, you get elevated to the status of expert amongst your peers. Right, Taran?
Yes. So I think as Taran mentioned, there are three important takeaways from this session. One is that you need to know what is the radiological development of a normal elbow. The second thing is you need to recognize between the radiological and symptom mismatch. And whenever you find these two things happening, the third thing you should be able to identify which investigation you need to get. Because here in trash lesions, it is more important to diagnose than treat. It may be sometimes difficult to diagnose and easy to treat. So these are one such lesions. So if you get three things, and always remember to compare it on the opposite side, as Taran has also shown beautifully, even if the abnormality can happen on both the sides. So normal will give you a lot of clues. Fat pet signs are good things to look for. So if you do not have a good quality X-ray, always take one in your clinic. I think that brings us to end of a very nice and exhaustive session on trash lesion. We can claim this to be the biggest and longest session on trash lesion in India, for sure. Sandeep.
Yeah, absolutely.
I think
it was a good session. It's a worthwhile start to the Saturday evening, and I think it's time to hit the bar. So cheers to you and enjoy your Saturday evening. Any questions you can always put up on the group and talk to us.
Sure.
Shall we call it a good night?
Yeah, I think so.
Yes.
Thank you, sir. Good night.
Good night, sir. Thank you.
Okay, thank you. Good night, everybody. Enjoy your
Thank you,
weekend.
sir.
Yeah.
Thank you, sir. Good night.
Thanks, guys.
Good night, sir.
Have a good
Thank you,
night
sir.
and a
Good night.
great Sunday.
Thank you, sir.
जय जय जय